Dr. Bhatia's presentation on graft assessment using transit time flow measurement, TTFM. Dr. Bhatia, the floor is yours.
Thank you. So I'm going to speak a little today about assessing basically flow in bypass grafts after bypass has been completed during open heart surgery. Is there a way I can change this?
Oh, yes, of course. We're high tech here.
Well, that's good to know. So the question is why evaluate bypass grafts, especially in the setting of beating heart surgery, but really in all aspects of coronary bypass. You know, the surgeons do, in their mind, and the best job that they can, but still, we have very mundane ways of evaluating the flows in these bypass grafts prior to using this type of technology. So the current state of affairs, there is a quality control for 70% of CABG procedures in the United States. Is it inexpensive to assess these grafts? Yes. Is it convenient? Yes. And is there a correlation to quantity and quality of blood flow? Questionable at best. So here are the alternatives to evaluate graft patency. You can do a post-op angiogram, but that is the gold standard, but it's too late because you've already finished the surgery, the patient's closed, and if there is a problem with a bypass graft, then you are faced with primarily non-invasive ways to repair them, which are sometimes substandard.
Well, especially if it's an anastomotic issue.
Correct.
You can't fix an anastomosis with the stent.
That is correct. Now you can do a post-operative MRA similar to the post-op angio. It gives you good images. It's expensive, and again, I think it's too late in the clinical algorithm. You can palpate the graft, which is what everybody does prior to this type of technology, but pulse is not the same as flow. So you can, even though you have a good pulse in a graft, that doesn't necessarily mean that there is good flow. Like you mentioned, Joe, there could be a distal anastomosis stricture or a stitch in the wrong place, and you'd still have a pulse in the graft, but you'd have poor flow. You can look for EKG changes during the coronary bypass procedure, but then again, a lot of patients don't necessarily have changes in their EKGs, even in the presence of a substandard bypass graft. And then you could observe the color changes in the myocardium, which I don't find to be too helpful overall. So the conclusion is that there really is a need for an objective and accurate verification method. In other words, how do we really assess the flow in the bypass graft before we close the patient? Now, what's the rationale for graft assessment? Obviously, the ultimate goal is we want graft patency. So the rationale is that you have overall improved patient outcomes if you can prove that you have technically excellent grafts. It helps in teaching centers where surgeons in training who may not have the experience technically to perform a perfect anastomosis. This type of graft assessment technology would show that. Also, it's good for documentation for your peers, especially cardiologists, who, when we do know that grafts go down despite ideal situations, and at least we are able to have these wonderful waveform graphs on the patient's chart, and they can see, and we'll talk a little bit about the flows and how to interpret a good flow tracing. It protects your referral networks because, you know, if you do good work, obviously that's how you get referrals, and not only from your cardiologist, but patients go out and talk to other patients. And
I probably shouldn't say this, but I've seen some people with some abysmal results still get referrals.
Well, that's true, but
I'm sorry.
But again, back to the rationale, you do want to at least try to optimize your outcomes so you can have that type of reputation, right?
Mm-hmm.
So,
yes.
And then most importantly, it gives me peace of mind because at least I know that if I've done the best job I can and those graphs look good based on the flow probe analysis, then I know that there's nothing more I can do to improve what I've already done. The flip side of that is that you could find, and we'll also talk about this, a substandard flow tracing, in which case you have to decide what to do intraoperatively right then and there. We'll talk a little bit about that as well.
Good.
So the rationale for graft assessment, even though the majority of cardiac surgeons are happy with a less than 3% mortality rate, patients obviously are looking for angina relief, relief of their chest pain, and certainly hope of no additional intervention, especially in the immediate post-op period or within the first 6 months to a year. The prevention of additional intervention represents benefit to insurance companies, private payers, Medicare, and really society, because anytime some of these interventions have to occur, they are eating up cost, and healthcare dollars are being paid attention to quite a bit these days, and so it really benefits society in general if we can save money on not having to do reintervention on patients. Obviously, we mentioned just now the cost of reintervention. It's very expensive to go back in and take care of a patient who has a problem that could have been taken care of intraoperatively. There's various DRG codes that also go along with the cost of I say average cost to treat these people if something has to be done in the post-op period. And they range anywhere from 10 to, in the slide says, 16, 17,000, but could be even more than that, depending upon the hospital course. So, but the cost of complications are very important. The increased hospital in a mortality, a patient that does not make it, the cost increase for hospital costs goes up 236%. And we know why. Why? Because these people, we throw the kitchen sink at them and we do everything we can to try to save them. And that may take a week or two and they ultimately pass away. The cost goes up tremendously. And then again, in patients who are hurt but don't die, basically have a serious non-fatal morbidity, that cost goes up by almost 200% as well. The point of this is that if you do a good job and you are happy with your grafts and you've proven that, then the chances of these things happening are very low. Here's an interesting number. Almost 20% of bypass grafts that are put on coronary arteries during open heart surgery are suboptimal. Wow. Almost 20%, that's 1 in 5. And that was in a study by Herman. Almost 1,000 cardiac surgery patients that underwent arterial and venous bypasses, they found some sort of abnormal grafts in almost 20% of the patients. Now, that's 1 in 5. I don't know any surgeon that would really accept that knowingly. Point is that these are found in the post-op period with the gold standard of angiography or MRA like we spoke of, where nothing can be done intraoperatively at this time because the patient's already closed up in the ICU or on the floor, or maybe even in the post-operative period they're out of the hospital. So what can we do to decrease this number? So we talked a little bit about mortality associated with abnormal grafts, and we know that poorly functioning bypass grafts are known to be associated with morbidity and mortality. And that study was done from women, where 54.7% of the 223 patients who died in the immediate post-op period had a gross technical problem. Wow. And that means that the bypasses either had unrecognized twists, conduits, distal anastomosis, stenosis, or dissection. So we know that using transit time flow measurement is cost effective, it's really easy to use, and it's a wonderful method to assess graft patency. So we'll talk a little bit about the technology and the types of probes that exist and how you actually do this. It gives you an accurate and quantitative real-time flow measurement. And I think that's really important because you've done your bypass, you measure this bypass graft, and you can see the flow, the pulsatility index, and the diastolic filling.
Sorry.
Based on the difference between upstream and downstream ultrasound transit time. This is tested and reliable technology. It's independent of vessel cross-sectional area, and the reason is because there are different flow probe sizes. So if you have a small vein graft or a small mammary artery, you have the associated probe size that will match those and give us the accurate flow rate in the bypass grafts. So the things that we look for when we do these types of analysis is a pulsatility index, a mean flow, a diastolic filling, and a waveform. And you can see, we can see this, right, everybody?
Oh, yes.
Okay, so the middle graph there with the waveform is what we will see. Now, there's some interesting things on that one we can talk about in a bit, but on the right-hand side of the slide, you see the various probe sizes, which go anywhere from 2 millimeters, I think, up to 10 or maybe even 12, because this is a usable technology in even the peripheral vascular and carotid circulation.
Oh, yeah.
So you get feedback on graft functionality immediately, which I think is the most important thing. We can see in the top center graph, there's a well-functioning mammary to LAD graft, which shows a good flow rate, a beautiful pulsatility index, and a great diastolic filling. We will also talk a little bit about that in just a moment on what we actually look for. You can see in the lower middle center, that's a poor waveform, and if you saw this, you would certainly not want to leave the operating room without doing something to that particular graft. The middle lower shows a vein graft to the circumflex with a very low flow, a high pulsatility index, and a low diastolic filling. You really want high flow, a low pulsatility index less than 5, and a diastolic filling of anywhere, depending on whether it's the left side or a right side, between 50 and 75%. So look what happened after the surgeon revised this. Now the same bypass graft shows a wonderful flow rate, a low pulsatility index, and a diastolic filling of, I can't see, I think 57%, within acceptable limits. Now, the triangle of coronary graft patency in this technology, as we've been talking, we need a good pulsatility index, a good mean flow, and a good diastolic filling. And for transit time flow monitoring to be correctly interpreted, flow curves, pulsatility index, and mean flow values should all be evaluated together. So you can't just look at one thing and say that your graft is good. You have to, all three have to correlate, and they all three have to be within the ranges that we look for when we measure these bypass grafts. So how do we interpret the flow probe analysis? You can see, again, another picture of a flow measurement in a graft, and you see the 3 numbers in black. The upper left is the 19. That is the flow that's measured in the bypass graft. The upper right is the pulsatility index. That number should be less than 5 and ideally less than 3. And a diastolic filling of anywhere from 55 or 50 to 75%, depending on whether it's a right or a left-sided bypass, meaning right coronary versus the left-sided coronaries. So what's normal? In the anterior and lateral wall for a mammary to LAD, a mean flow value of anywhere from 32 to 50 milliliters per minute. I've seen even higher. A pulsatility index of 3 plus or minus 1.1. I've seen them as low as less than 1 before. And diastolic filling of 70% plus or minus 10%. So the left-sided diastolic filling should be a little higher than the right side due to the pressure differences on the right versus left.
Would you mind if I interrupted you just for 1 second? Okay,
sure.
So for the audience out there, and it's for me too, okay, so I'm blaming the audience for my deficiency here.
Which are many, by the way.
Touche. Thank you so much. Explain Pulsatility Index. Okay, I understand flow. I think everybody gets that. Everybody probably understands flow. I think everybody understands diastolic filling. That's when the coronaries get filled. You want it to be higher, not lower. But what exactly is Pulsatility Index?
Well, it's a measurement that has to do with, and really from a clinical standpoint, what it means is resistance. So if you have a high pulsatility index, that basically indicates that flow going down the graft is somehow obstructed.
Okay.
Okay, and there is a physics formula. I think it's the high minus the low over the mean, something like some calculated number. But
Okay.
But how it translates clinically is that it shows the clinician and the surgeon that there is some sort of outflow obstruction. Is it a stitch at the distal anastomosis? Is it a mismatched conduit to artery? In other words, you've sewn a big vein to a small target and there's some sort of obstructionary flow. Is it distal outflow obstruction that is more distal than we see? In other words,
You put the
bypass on the soft area in the vessel, and there's distal disease.
Okay.
So there's a lot of different things, and those are types of issues we come across and have to figure out if we want to revise a bypass graft because of what we see. But I think personally, the pulsatility index is probably, I mean, all three are important, but that's the one that if you see one that's higher than 5, you really need to kind of think about, is there something that we did technically that can be fixed? In other words, do you redo the bypass? Do you take it down? Do you endarterectomize the coronary artery? Do you, perhaps find a smaller vein that could fit on a small artery? I mean, there are a lot of different things that you're going through your mind as a checklist when you see that, but that's basically what pulsatility index is.
So pulsatility index is resistance. So that for the audience who's trying to listen to this, when you keep mentioning that, they can sort of in their mind formulate PI is equal to increased resistance.
Increased resistance. That's
for
correct.
some reason.
For some reason. Could be a lot of different reasons.
Could be twist, could be distal disease, could be mismatch, could be whatever. Okay, I'm sorry to interrupt you. Thank you.
Here's another example of a left-sided bypass where we have a vein graft to the circumflex. Mean flow values, again, anywhere from 30 to 50, pulsatility index about the same, and diastolic fillings 67 to 80, 75%. And these are just from a couple of studies that they actually looked at different numbers of bypass grafts and came up with this. I'll say that, you see values, flow values of 32. I've seen them as high as 100 before. So you can see really high flow bypass grafts with low pulsatility index and no evidence of competitive flow, which we can talk a little bit about that as well. So there's nothing wrong if you see one that's higher. It is my point. In fact, it's probably good. You're pumping a lot of blood to the coronary arteries. And that scenario really occurs when you have a beautiful vein and a very nice distal target to bypass. It's the ones that the fellows would get to sew in a training program because they're just so nice. Here's one of the mammary, the right mammary to the right coronary artery. You have a nice flow of 60 milliliters per minute, pulsatility index 1.9, but notice how the diastolic filling, because of the pressure differences on the right side of the heart, are a little lower and acceptably lower. So you can see anywhere from 55 to 65% diastolic filling.
Now, is that a mammary that's in situ?
That's the right mammary to the right coronary artery,
and
in situ.
It's in situ.
Yeah.
So how much of that is related to, well, no, I guess it wouldn't really make any difference because you put it on the aorta. It really doesn't make it difference. It's a mammary in situ as opposed to a vein graft. It really doesn't make any difference. Okay.
Not from a diastolic filling standpoint. These are just, no, it doesn't make a difference. And then here's the vein graft to the right coronary artery. Again, just very similar numbers. You see a diastolic filling of 49% there. That's totally acceptable on the right side of the heart. So again, just to summarize what we talked about, very important. You want a pulsatility index less than 5. a diastolic filling greater than 50% and a flow rate greater than or equal to the expected value. So say you had a graft that had, flow of 5, but a decent pulsatility index and a decent diastolic filling, you may, again, go through that checklist in your mind. Is it just due to a small artery and, low outflow? There are a lot of different things that you go. Could even be spasm, for that matter. Mm-hmm. So we need to go through these things when we see these abnormal numbers. It's very easy to do examination of these bypass grafts, and you get a nice flow rate and nice flow, and the curve looks good, and you're fine. Mm-hmm. But the question is what do you do when you have the abnormal ones? Mm-hmm. And that's the most important thing, because those are the patients that if we do intervene on before we close, that we can potentially save all those complications post-operatively, as well as the associated costs that are associated with the taking care of these people. Mm-hmm. So the summary: what is normal? Left heart versus right heart. The filling pattern on the left is diastolic dominant, and the filling pattern on the right is somewhere between systolic and diastolic. The other thing, the ACI is called an acoustic coupling index. That's another thing we didn't talk about. But when you do these, put these probes, these flow probes on the bypass grafts, you want the coupling index to be in the green. Now, all that means really is that all the sides of the bypass graft are in contact with the metallic portion of the flow probe. So
that's how you size it.
Size,
you
right?
Know your size. First, you eyeball it. You pick a probe.
Right. You see a vein that's probably either 3 or 4 millimeters. If you took a 5 millimeter probe, the vein would essentially be kind of loose in there, and you wouldn't get a good acoustic coupling index. And that on the screen will be green when it's good and yellow when it's bad. So you want to make sure that that's green. You want to make sure that the waveforms that you see are repeatable. You want to see little retrograde flow, and that's what shows the competitive flow in the tracing, and that's basically a filling that you will see below the x-axis, below it. So normally you see that nice waveform above, and if you get a little dip below, that shows that you're getting a little bit of competitive flow, meaning that you have potentially bypassed a vessel that's not as stenotic as was told or seen in the angiogram.
Which is likely to then go down.
Potentially. Mm-hmm. You want a pulsatility index of less than 5, diastolic filling greater than 50%, and flow rates greater than at least 15, unless you suspect that there's some anatomic issues within the heart that would prevent that kind of flow. So during flow measurement, you should be suspicious of any flow that's really less than 15 or a high retrograde flow greater than 3%. How do you assess that? If it was greater than 3%, you would say, okay, well, maybe this is competitive flow. So all you got to do is put a bulldog or something to occlude the proximal flow in the native artery, and then if that diastolic, the dip goes away, then you would probably be able to assume that there is a degree of competitive flow. Mm-hmm. Now, you asked about what pulsatility index was. Here's the equation. It's max flow minus minimal flow over mean flow. And it's a good indication of graft and runoff resistance, as we spoke of. It's an independent indicator for graft longevity, meaning that if you have a pulsatility index greater than 5, or certainly in the 8 to 9 range, that the chances of that graft staying open are going to be lower. And what is clinically acceptable? We obviously we want less than 5, but 3 or less is even better. And we talked a little bit already about diastolic filling, always greater than 50% in the coronaries. More balanced with systolic filling on the right side of the heart. On the left side, the heart filling pattern is predominantly diastolic. That's why we see the higher percentage numbers. Now, how do you spot a bad graft? This is
This looks bad.
This is clearly one that you wouldn't want to potentially walk out of the operating room knowing that you thought you did your very best. This is an occluded mammary to the diagonal. You got a very high pulsatility index, 12.1. You've got a flow of 2 milliliters per minute and a diastolic filling of 6%. So none of those are within acceptable limits. And, I would suspect that if you didn't have this technology, you could feel that mammary and you would feel a pulse and you would think you did a good operation, a good bypass. But this clearly shows how you can prove to yourself that no matter how good you think you've done, there may always be some room for improvement.
Now, I know that I had promised and we discussed that we were going to be serious today, but this case here, so what you probably had to do in that particular circumstance was go ahead and put that patient on bypass and then revise that graft?
No, absolutely not. First of all, this is not my.
This was not his case.
Yeah.
Okay? This would never happen.
If it was, I would certainly not go on pump. I'd just take the thing down and redo it, which we have an example of coming up.
I'm so sorry. I'm sorry. I'm sorry.
Okay, so let's talk a little bit about this flow wizard. You can put what on the screen what is the expected look of a flow tracing on a normal. I don't use that. I've done it enough times to know, but for those who are just starting to use this, it's a nice tool to have where you can see what you should have in terms of flow and pulsatility index and the diastolic filling. And you can see the difference in the center box, which is a normal tracing and an expected tracing in this type of bypass versus the crappy filling flow on the bottom. I can't see on the bottom right, I guess. There's just not, it just doesn't look nearly like it should. Now here is an occluded mammary LAD, very similar, low flow, high PI, and low diastolic filling. And then what you were speaking of, when you revise the mammary to LAD in the same patient, look at the difference that you get. You go from 2 to 49, you go from 12.1 index to 1.2, and you go from 6 to 65% in diastolic filling. That is a normal tracing, and that's what you want when you close a patient up and walk out of the operating room, because that graft on the right will stay open. The one on the left might be open until you get to recovery room. In the instance of a kinked graft, you can see that you have small flow, high PI, and a diastolic filling that kind of says, there's something wrong there. It's not so low that you think it's occluded, but it's not in that area of 50%. And you can also see that you have that dip in the curve below the x-axis. Those are things that can potentially indicate that you have a kinked graft. And again, after revision, you can see how beautiful the curves look. So to summarize bad graft analysis, you see low flows, high pulsatility index, and diastolic fillings that are less than 50%. If you see abnormal retrograde flow, again, that could be a kink graft, that could be competitive flow, primary systolic filling, meaning that you have no runoff, absent or reduced diastolic flow, combined with high systolic flow, that also indicates a technical problem. Spasm, if you have arterial spasm in a graft, what would you do with that? You can give some pharmacologic papaver and verapamil, put on the vessel, and come back and reassess it before you close. And I have seen instances where you do get spasm in the mammary artery, and then you just give it a little bit of time, and you come back and check it, and it's just a beautiful waveform. So you don't always have to just knee-jerk, we got to redo the bypass. Give it a little time, let things settle down, and then come back and reassess. You have time to do that. It's not like you're going to close within a minute after you've finished all of these anyway. Let's So what do? We talked again, the acoustic coupling index should be in the green. Another important thing is that the mean arterial pressure needs to be near 80. So say you have a patient that you've done beautiful bypass grafts on and you're measuring with the flow probe, and the pressure is 70 over 45 with a mean of, which can happen, with a lower mean, you're going to get a low pulsatility index and a decent diastolic filling, but you may have low flow. And so all you need to do is raise the blood pressure and get into an acceptable mean, and you'll see that flow go from 30 to 70 just by raising the blood pressure. The other thing is very important is the placement of the probe, where we put these probes when we're assessing the flow. You don't want them near the proximal anastomosis, you don't want them very near the distal anastomosis, and you don't want them on curves because the curves can simulate a kink. So you want to put it in a nice area where we know that there's no obstructive flow, and the probe size is incredibly important. We talked about a big probe in a smaller vessel. The opposite is even more important. If you use a smaller probe on a big vessel, you create a kink or you create a partial occlusion. And so the flow is going to be less than it would be if you had a normal size probe that fit the vessel. So yes, it is based on eye measurement, but sometimes you have to open up an additional probe. They're not disposable. You just re-sterilize them, but you may open up one that you don't use, but that's okay. The important thing is to make sure that you have one that fits exactly right and is in the right position. So when we do find the abnormal flows and the things that we don't like, that we're not comfortable, so the easy stuff we have to check for first is spasm. We see a spiky waveform. Kinks, where we talked about you have a low flow and a high pulsatility index. Kinks are equal to occlusion, basically. Twists, again, low flow, high PI. All of these are just by examination. I mean, we obviously know how to see a kinked vessel and a vessel that's twisted. And then length of the vessel. Sometimes you cut the vein too long, and so you have basically a low or a flat diastolic filling because the length of the vessel is too long. This is kind of a long slide. I'm not going to go over all of it, but the important thing is that we talked about low pressure, how to, the easy fixes. So low blood pressure, you just want to raise the blood pressure. Make sure you have a mean arterial of 80 or greater. The time point, I think, is very important. Nothing wrong with waiting and remeasuring. If you have a bad flow tracing and you're pretty sure that everything was done perfectly, just wait and come back in 5, 10, 15 minutes when everything settles down, and then remeasure. There's not much you can do for competitive flow. Once you've done your bypass, it's there, but you can prove that is what it is by occluding the proximal inflow. It's very easy just to put a little bulldog on the proximal native coronary.
And you're generally relying on
coronary angiogram
and on a diagnosis from your referrer.
Right. IVUS kind of has helped avert some of these things. We can clearly see much better the degree of stenosis in the proximal vessels. Arterial spasm we spoke of as far as applying a vasodilator directly on the bypass graft. This is typically in the mammary arteries, not the veins so much. And then if none of the above seem to fix the abnormal findings, then you have to decide on the next step, which is consider redoing the graft. Now that is easy to read, but very hard for a lot of surgeons to do, to say, okay, well, I'm just going to redo this. I think I've done the best job I can. It couldn't possibly get any better. But in reality, with the 19% abnormal graft finding, it certainly could be redone and perhaps improved. So a little word of caution on spasms. As I mentioned, the mammary, arterial, bypass conduits are the ones that spasm. don't forget that sometimes the runoff bed is arterial, and it also can spasm. And so a direct injection around the artery with a small tuberculosis needle, TB needle, I've done that as well, and that also helps.
Did you ever squirt a little nitro down the coronary?
Have done that as well. So again, approaches are to apply the vasodilator after harvesting, which I do 100%. We inject the mammary artery with either papaverine or verapamil, and we soak it in a sponge that has verapamil and papaverine on the sponge itself. And we let that sit for, 30, 40 minutes before we're ready to use it. And so that vessel is quite dilated by the time we're ready. Remeasure after you have given the vasodilator in whatever way you're going to do it. Sit tight for 10 minutes and then remeasure. So what if it's not the easy stuff? What if it's really the hard stuff, meaning the anastomotic, greater than 90% of the anastomotic technical problems are at the toe. We know that, right? So it's easy. You can't miss on the side usually because it's not going to affect outflow. And the heel doesn't matter as much, but the toe end matters because that's where the distal flow goes. And so if you have a stitch at the toe portion, you will see a high pulsatility index, very low flow, and mostly systolic filling. And it's a little bit about on versus off pump, when to measure TTFM. In my opinion, you should measure it on all of them, okay, whether you're on or off. But the timing intraoperatively does vary. So when you're on pump, the time to measure the flows is when the cross clamp is on the heart and cardioplete. Using cardioplete, you can check your distal anastomosis. When the cross clamp is off, but you're still on pump with the heart beating, you can also check the distal anastomosis just to make sure there's no kink or twist or any proximal anastomosis issues. So the hard part, I think, is for on-pump surgeons to measure flow rates when you're off pump and either given protamine or just about to give protamine. Your cannulas may even be out. And now you're measuring your graft flows and you see a problem. The decision is now, what do we do now? Do we go back? Do we recannulate? Do we go back on pump? Do we re-heparinize? All the things that nobody really wants to do after they've completed an operation. But the important thing is to have the desire or the willingness to do that if you see a flow tracing that is suboptimal. In the beating heart surgery arena, it's a little bit easier because the heart's already beating and you've completed your, for example, a mammary to LAD distal anastomosis. Very easy to just quickly put a probe on. You're still heparinized, the heart's beating, and if there's a problem, you can immediately take it down and redo it. Yet another reason of superiority of beating heart surgery versus on pump surgery. They talk about snare tests to check for competitive flow. I just use a bulldog. I don't think the snare is really something that's used that much. Anyway, the final check should always be after the retractor is removed and right before chest closure on both scenarios, on and off pump. There are various times during the surgery that you can check these things. Again, we talked about waiting a little bit and coming back to reassess these bypasses, and I think that's a very good idea in both arenas, on and off pump. Mm-hmm. This is an algorithm that summarizes a little bit what we talked about. I won't go over everything, but with the pulsatility index less than 5 or even less than 3, that's a good graph. Leave it alone. You got good flow, good diastolic filling. On the other side, greater than 5, low flow, low diastolic filling, likely a bad graft. And what's important, I think, again, is that you should consider redoing that graft or fix it if at all possible. I mean, obviously, patients trust us to take them to the operating room and do bypasses on them, and they want, just like we want, the best outcomes for them. Technique does matter. Here is a couple of examples of measuring a bypass graft with the graft elevated. And you can imagine anything that you do to impede flow down that bypass graft is going to show and translate in a flow measurement on the graft like we see here. Once the graft is relaxed and let alone, you can see how the flow and the, really more importantly, the Pulsatility Index dropped from 3.9 to 1.7. Everything else was relatively the same. These are minor things that you get to learn and see as you do these more often. But once you become more comfortable with it, it's a very good tool to have to assess your patency. If you measure the graft too proximal, you can see how the flow is diminished. Even though the Pulsatility Index on both scenarios is acceptable, one is 1.3, the other is 0.8, you can see how once you move the probe down to the mid portion of the graft in a non-kinked area or a non-curved area of the graft, that the flow rate goes up and the diastolic filling gets a little bit better, which is what we'd expect. A couple of studies Dancona did, 409 patients, the method off pump surgery. 376 patients had no revision, but 33 patients had a revision. That's an 8% revision rate using transit time flow measurement, which showed that those grafts, and there's various reasons for revisions on the slide as well: thrombosis of the anastomosis, stenosis of the toe or heel, 8 patients, intimal flap or dissection of the native vessel, 5, and it goes on and on. But these are things that I think most importantly is, had we not or had they not looked at that with the flow probe, 33 patients or 8% of them would have gone to the recovery room with substandard bypasses.
Mm-hmm.
The European Journal of Cardiothoracic Surgery also did a study, and their recommendations in the European guidelines was that graft flow measurement related to type, vessel, and size, degree of stenosis, quality of outflow area is useful at the end of surgery. And flows less than 20, at least in their, we say 15, but less than 20, and PIs greater than 5, predict technically inadequate grafts and the high potential for failure. And this should mandate graft revision before leaving the operating room. They say theater, but before leaving the operating room. That's a very strong recommendation. Let's talk about a little unexpected results. So this is one that was actually local. There was a patient who was operated on by a very gifted cardiac surgeon right here in Houston. It was me. And had a single vessel mammary to LAD. Case went so pure and perfect. Great pulse in the mammary artery. Clinical observations were normal. The patient had no changes in hemodynamics. The TEE appeared normal. The anterior wall was moving fine. Palpable pulsatile flow in the mammary. And the conclusion clinically without the flow measurement was that the graft was patent. Literally, the patient had no sequelae at all, didn't turn a hair at all. This is the flow that we measured in the anastomosis, in the flow of the mammary to LAD. You can see basically that the flow is 2, the index is almost 30, and the diastolic filling is 26%. That's not spasm. I mean, that's obviously, there's something very wrong with that bypass graft. And this patient would have gone to the ICU with that, and we all thought that the patient had a great operation. So I revised the bypass graft, and this is what we found. So we went from a flow rate of 2 to a flow rate of 29, a pulsatility index of 29 to a pulsatility index of 2, and some diastolic filling of 66%. You can even see a little bit of competitive flow with the spike below the x-axis. But this graft is going to stay, this graft's going to close, this bypass, and this bypass will stay open probably the rest of his life. So, you know, you can't be too proud to say that, you know, we have all had substandard bypasses, and for whatever reason, I don't know what this was, but whatever it was, I didn't like it, and I redid it, and we got this result. And so I think you have to have the mentality in your own heart and your own brain that if you get something like this, you just can't leave it alone. You have to. You can't be too proud to say I've done the best job I can and I can't do any better, because that certainly can be improved upon. So that was a nice result. Patient ended up doing well, going home, is doing well to this day. But in about 90% of the time, the flow probe just confirms that we have a good outcome. And I sleep better, and I think most surgeons would sleep better knowing that if you can catch 8 to 10% of bad outcomes or bad anastomoses or just reasons that that cause bad flow in these bypass grafts, and you can do something about it, you know, you've obviously helped that patient. So that pretty much ends my talk, and I'd certainly be happy to answer any questions. I know we're going to have a discussion about it in the panel, but that pretty much ends what I have to say.
I have a question.
Well, we have a whole bunch of questions.
Okay.
So what I'm going to do, if I could, let's go ahead to full screen. Let's open the phone lines, and let's, in interest of time, I'm going to forego the on-pump, off-pump discussion because actually I think this is such an important topic, and we're going to just, I think, have an open discussion for the next 30 minutes or so. And so if that's okay with everyone else.
Yeah.
Okay, so Deborah, I'm sorry, please, your question.
Okay, my question. Thank you very much for that presentation. Given the 19% of the inadequate patency rates,
Yes.
is this data required on STS
Oh, good question.
where actually this would be documented? So
Well, if it is, it would be listed in the outcomes section of, and we're moving more towards that, where we're having individual outcome
Right.
reporting, and but that particular study, I think, showed patients who underwent angiograms postoperatively.
Right.
They don't all do that, so it's
exactly.
hard to say. But I think that in the patients that do fall out, either be through readmission or a subsequent cardiac cath for an abnormal stress test, say in the postoperative
But
period,
right.
it is reported, but not individually by graft failure.
Right, we catch it because I haven't collected STS data in a while. People in the audience may be doing it, and I don't recall that being intraoperatively. And if we did it at the point that you're talking about, I mean, it sounds like we would actually reduce cost, morbidity, mortality.
Well, we
in
do
the
for
patient
sure.
population.
We do
So-
for sure. Now, I don't think that a surgeon should be penalized
Absolutely
for discovering that an anastomosis is suboptimal. In fact, it should be the other way around, that you have found something and fixed
not.
it
Exactly.
and saved a patient a lot of grief and saved a lot of hospital costs.
Well,
And-
even documenting after you fixed it, not necessarily
Right.
until once you can show
Right.
that, okay, I have validated that this graft is patent.
Well, it would be nice to be able to have those numbers on every patient you do bypass on, and say these grafts really all fell within the acceptable limits of patency, and use that in the STS. It's not right now, though.
Okay, thank you, thank you.
I have a bunch of questions. And just a reminder to the audience, the phone lines are open. So if you want to call in. And you guys want to join the discussion? Yeah, please come on up. So we're going to bring up Stephanie and Rodell. They can come sit over here, and we'll get some more questions, because we're going to be here for a while talking about this, because I've got a bunch of questions.
I got another question, but you can go.
You want to go?
No,
you
can
go ahead.
No, you can go.
No,
now.
you go. No, you go.
Fine,
You're
I'll
my
go.
guest. You get to go.
Now, my other question was about surgeons that actually utilize flow and pressure with their cardioplegia system. So you're on pump. Comparing that method to validating graft patency or your distal versus this method.
Well, I think that,
Is
that
right?
was one way to do things before, maybe even before we had this technology,
Right.
and it was certainly better than the finger palpation. It does give you some good data, but not probably as good as what we see with the TTFM.
So what's the disadvantage, or why are surgeons not using this more?
Well, I think a lot. No, it's really not. It's not a. I think there's a few things that you could
Hi,
say.
you're on the air, but
One
hold on,
is
please.
just lack of education.
Hold on, please.
And the other is maybe they don't want to see it. I mean, I'll be honest with you.
Well,
maybe
thank you
that's
for being honest. I appreciate that.
I think that's good. That's a
Yeah,
very good.
exactly.
Actually, I'm glad you're being honest.
Yeah.
Because I think that's something that is lacking at times. But that's part of my questions too. Hello, you're on the air. Could you please let us know who you are, where you're calling from?
Yes, I'm Doug Nyford with Medistem, actually, calling from San Antonio at the moment.
Okay. Well,
Hello, Dr. Bhatia.
Hey, Doug.
Hello, Joe.
hey. Go ahead. What's your comment?
My comment is that it's an excellent presentation, Dr. Bhatia, and Joe, you actually asked some good questions. I'm impressed. So thank you for that. And did you want me to add something about other uses for this device?
I do, actually. I'm glad you bring that up. Actually, you and Dr. Bhatia can perhaps talk about it. Can you guys discuss maybe some, because Doug told me he was in San Antonio, and he said that he was in San Antonio doing liver transplants and using this device for them. And I was like, well, what other kind of cases can you use this for?
Well, I mentioned in the discussion that this is, from a cardiac surgery standpoint, a lot of us also do peripheral vascular and carotid surgery. And so you can certainly use this technology to measure flow in FEMPOP bypass grafts and carotid endarterectomies and things such as that. I know that it's also used in the liver transplant arena, but I'm not really that as knowledgeable about that.
Well, I thought it was interesting. Doug, can you describe how you use it with liver transplants? Because I found that really fascinating.
Yes. There's a particular interest in the living donor liver transplant community, and I don't know how the word has gotten out about it, but we're getting calls now from all over the country to bring our machine in and demonstrate it to them. And what they're doing is with the living donor, they will sometimes measure the in situ flow prior to removing a portion of the donor's liver and, of course, putting it into the recipient. And then to see what kind of flows were going into that liver. And then they use the machine to actually measure the hepatic artery flow and the portal vein flows. And because it's a partial liver, all the vessels are used to pumping, of course, to a whole liver. So sometimes they have to modulate those flows so that they get a correct ratio of flows into and out of that partial liver. And they find it, if they don't, they can have all kinds of complications.
Mm-hmm. Yeah, that's interesting. And you can use it on the aorta too, is that right?
Yes,
Okay.
we have a big enough probe to actually use on aorta.
Mm-hmm. Would that be of any value? Let me ask Dr. Bhatia, would that be of any value on let's say a AAA, where you did it as an open AAA? Is that of any value on a vessel that big?
I mean, I haven't used it in that scenario, but I think it is important to use it in a peripheral bypass because, again, you're relying on a good distal anastomosis, and say in a femoral popliteal bypass, or even an anterior tibial or posterior tibial vessel, which tends to be a smaller vessel. You want to make sure that anastomosis is as best as can be, and it also gives you a good assessment of your outflow in distal extremity. So,
how is Doug, thank you so much. We appreciate your comment and question.
Yes, sir.
It was very helpful. Thank you.
Yes, sir.
Bye-bye. Okay, so I do have a lot of questions, but I defer. Do you guys have any questions?
I do. I have
Please.
a question. So I'm just curious if you're happy with where the technology is now, or do you see like big room for improvement?
Well, I like the technology that exists. There is some, I didn't discuss it, but there's some actual visualization techniques that you can measure the distal anastomosis and actually see your your anastomosis onto the vessel where there's no, if there is some sort of technical problem, you can actually see that.
That reminds me of like IVIS.
Yeah,
right?
but this is something, and I don't use it. I think what I have is acceptable, but but I think a lot of people do, and it's probably,
So it's a growing field.
Oh, it is, and they're all. I think they're constantly trying to improve what they have.
Great. And I have one more question before
Yes.
Joe takes over.
I am doing a really good job today deferring. All right, that's not my usual.
I
It
believe
is
it.
not
Okay.
usual. So.
So I'm wondering, we have some surgeons that do a lot of endarterectomies compared to others. And I see the reasoning of if you're trying to graft on and you have to get that plaque out. But what is the reasoning of some surgeons wanting to do that, even maybe
Versus not.
50% of the time? Do
Yeah.
you get better flows? Is there
Well,
a
again, I
good
think
purpose?
I've done them before, and I think that it makes you feel good to be able to pull a piece of plaque out of a vessel and hope to have higher flow within that vessel. There's some downfalls to that as well, that you've made the vessel very prothrombotic, and you have a higher incidence of graft thrombosis or even vessel thrombosis when you do that. So if you're forced to do it because the lumen of the vessel is just too small, or you cannot pass a needle through a very hard plaque, then yes, I do it.
That makes sense.
But it's not a standard thing in my practice.
Could you get more competitive flow actually by doing that?
Potentially, yeah, absolutely.
Yeah, I'm glad you brought that question up. That's a good question because it made me think of something too, and that is, you have a vessel that's that long from start to end, the right coronary. It's going from the aorta ostia at the aorta around to the PDA over here. And you take a mid portion, you're going to do a distal right. You're not going to do the PDA. You're going to do distal right. You take a plaque out that's that long. Isn't that also still distal?
Yeah, I mean,
Isn't that continuous?
Of
Or are you
course.
saying or is it discrete?
Well, it depends. I mean, sometimes you have focal stenosis, and you can go out and take that area out, and there's nothing wrong with that. But then again, atherosclerosis is a systemic problem, and so we see even with for example, in carotid endarterectomies, we clean out what we can see in the neck, but we know that we could follow that plaque all the way down to the aortic arch if we could. So there are various clinical scenarios during open heart surgery as to why you would remove plaque in an endarterectomy scenario. But again, it's not standard, in every patient.
Okay, so I guess that brings me, Rodell?
No, I don't have a question.
No questions yet?
It was not yet.
No questions
Not
yet.
yet.
You look very nice.
Thank you, sir.
I like your bow tie.
Yes,
Very-
very
it's
New
very
Orleans.
chic.
Yes,
Very
thank you.
chic. Yeah, very New Orleans. Yeah, I like that. Which brings up, maybe you shouldn't do endarterectomies on every case, but you certainly should do at least some type of graft validation technology on every case.
In my opinion, yes.
Yes, and that's the point, is that it's not done. So, if you don't know, then it doesn't matter. How many places or how many surgeons do you believe in, let's just use the either Texas State or South Central region use this, or if around the country, how many use this versus don't? Because I've worked a lot of places, and we work a lot of places, and this is not really commonplace to us.
I don't know the exact number. I'm sure Doug could give us kind of a percentage of usage compared to total number of surgeons in the state or in the region. Again, we mentioned that it potentially is due to just lack of knowledge or education on it, or maybe, like I said,
Patience, time. Takes time, doesn't it?
it really doesn't take a whole lot of time,
But it does take some
It
time.
adds an extra few minutes, not a whole lot.
Unless you
The
find
time,
something
right?
bad.
The time that would be added would be if you found something that you needed to revise or do something about.
Now,
Mm-hmm.
you know what I haven't seen you do, and I'm wondering if it is useful at all. Can you actually check the flow of the native vessel to see if it should be grafted or not?
You know,
based on
I
flow?
haven't done
That's a
that,
good question.
and I don't know that. I mean, you'd have to circumferentially dig out the coronary artery to
To do
place
it,
the
so
probe
it wouldn't
around
be
it.
easy.
Well, and it comes with a little bit of risk when you're doing that
Makes sense.
between the septals on an LED, for example, or even just damaging the vessel. So no, I have not done that. I don't know that anybody has advocated that. We usually rely on the angiogram findings and,
Right.
So you're
preoperatively.
challenging the cardiologist.
Mhm.
That would be a challenge to the cardiologist, perhaps saying, I've decided you don't need to graft this when they've recommended
Well,
you
yes.
need to graft
Well,
it.
that's
So,
something that has been, I certainly picked up the phone and called
absolutely.
the cardiologist, and I think after, maybe in the early portion of my career, it was more of an issue, but now it's more of a, having 20 years of experience, that the cardiologists say, listen, if you don't think it needs to be bypassed, we understand.
And I've seen
And
that
there's-
shift in my career of it being more of a collaboration than and before it was in it and again where it was. So I think that's wonderful for patients. And I do want to thank you as a my family has cardiac disease, and a surgeon that operated on my mother was thoughtful enough to make sure, and she got 27 years
Wow.
of additional
Yeah.
life and a good
Wow.
quality of life.
Yes.
So
That's
I
great.
appreciate that as a patient family member. So
Very
thank
well.
you, sir.
I also wanted to mention, and follow up to what we were just speaking of, is that a lot of times, we hear more about hybrid procedures, where somebody, for example, may be just too high risk to have and I don't mean this in a negative way against the pump, but to be put on a heart-lung machine and have a complete revascularization and then come off pump. Sometimes that's hard. So say you have somebody that has multivessel disease, and you say, okay, listen, I can get in there, beating heart, put a memory on the LAD, you've got a protected left main, now you can go stent what you need to stent. And these types of hybrid procedures are happening more and more. And it just goes into further what you question about bypassing or not bypassing a vessel. So if there's something that I see intraoperatively that I think is either too high risk or just not worth doing, then I don't mind calling the cardiologist and saying, listen, I don't think we need to bypass it. Most of the time, they're okay with it.
That you brought up some good points. Let me first, if I may, talk about the, and since my talk was supposed to be about on pump versus off pump, I hear this a lot, and I do believe that the pump contributes. I think all of us that are perfusionists at the table can agree that there is an inflammatory process that is going to occur using the pump, and that there's going to be some, alteration in what is normal physiology from going from pulsatil to continuous flow and all of the dilution and various different things that occur. It's certainly it's beneficial, but yet abnormal. But it's a good thing. It's a good abnormal thing if there's such a thing. Okay. And I hear that a lot. Surgeons say putting the patient on pump is hard on them and then getting them off pump. And I would suggest that that isn't the issue at all. I think going on pump and having a stable circulation, notwithstanding there's these inflammatory things, so it's a balance of which is worse, is not the problem, but a benefit versus going on pump, clamping, giving plege on these sick hearts, because I don't think that cardioplegia is perfect at protecting the heart. So when you have one that's compromised and you have any ischemia, even if it is minimal with the cardioplegia, that's where the problem comes in, is the loss of circulation, reperfusion, lack of good protection, or you're certainly not at a state of zero entropy on the heart when it's clamped, and then the reperfusion, and then trying to come off pump. I think going on pump and doing the procedure without the clamp, in my view, is better. And I've always believed that.
Well, what you're describing is pump-assisted beating heart surgery.
Correct.
And I think that there's certainly usage for that. It shouldn't be probably not at all, because patients that can withstand just straightforward beating heart surgery where hemodynamics are stable, there's really no reason to do that. Now, just recently, just yesterday, I had one where I absolutely had to have pump-assisted, beating heart surgery. This guy just couldn't tolerate manipulation of the heart. Had very bad disease, and so there are certain instances and scenarios where I agree with you. It's a good thing to have in your back pocket if you need it.
Mm-hmm. Yeah, I think it's underutilized. I think some people get caught up, and I compliment you for being able to utilize the tool. However, of course, I feel like anesthesia has become, and it really is dependent on the anesthesiologist.
I agree.
Or the CRNA, as the case may be. But the really good ones can give you a perfect looking hemodynamic picture on the monitor. It looks great. But if you were really to measure coronary blood flow, cerebral blood flow, renal blood flow, mesenteric blood flow, brain blood flow, all the things that truly matter, you would find a very compromised, almost unacceptable perfusion, cardiac output, circulation, what they need, but you have a perfect looking clinical picture. And I think that's misleading to a lot of people, including some surgeons, who don't recognize the difference between a blood pressure versus actual perfusion.
Well, we do measure transcranial blood flow.
Well, you don't use TCD, you use cerebral oximetry.
But either way, that implies circulation to the brain, number one. Number two, we measure urine output. And as long as the kidneys are making urine, they're perfusing. To my knowledge, patients don't wake up with dead bowel, so their bowel's perfusing. They may have ST elevation or ST changes during the procedure, but they don't come out with positive troponins, so there's no myocardial infarction. There are things that we clearly measure and look at intraoperatively that do correlate with the perfect picture you're describing on a monitor. Now, do you have some alterations? Perhaps, but I don't know that they're so bad that you would need to use the pump to make it better.
That hurts.
Well, I mean,
I fundamentally,
I agree.
Fundamentally disagree with you. 150%. I disagree.
But we've disagreed for years.
Yes, and we'll continue to disagree.
But if you're making, I have to answer your question about, you're not perfusing the kidneys. Well, you are, because if you weren't, you wouldn't be making urine. And we measure urine output on an hourly or half-hourly basis. And especially when the patient's heart's being manipulated and they're in a Trendelenburg position or whatever, we do what we need to do to have good mean arterial blood flow systemically. Mm-hmm.
I think you just accept a certain level of compromise to get through the case.
Well, I don't know what I'm compromising. I think that
for that period of time.
Brief period of time.
Well, yeah, I think
so there's you know when you're past that level and need to go on, but there
Correct.
is a certain level of, there has to be
Yes,
a little
yeah.
bit of compromise in
Sure.
flow.
All
And
of it,
Yes.
there's a
you
risk
know.
benefits.
But
Right, exactly.
we're compromising coronary flow when we put bulldogs on the coronary arteries. The point is that
Right.
you
There's
do
an
our-
acceptable amount to
a few minutes,
Right.
and then you have to, or hemodynamic instability, and then if you can't fix that, then you have to go to the next level and just say, look, we got to either, do a full pump run and cool and clamp, or we do what we did yesterday, which is pump assisted and.
Right.
Well, a lot of that too, I think, is again, I think that there are surgeons, and I'm going to probably live to regret this, but I do
Oh, no.
think that there are. I have to. I think
Maybe
there
you
are.
should think for a second.
I think there are some surgeons who are very, very well experienced, skilled, have the technical capability to do beating heart off pump surgery well. I think the problem comes in that not all surgeons are created equal, not all perfusionists are created equal, not all astronauts are created equal. Everybody, there's the great ones, and there's the ones that are like middle of the road, and then there's the ones you wonder how they made it through. And we see it, and I've seen it several times. People who should not be doing off pump surgery struggle through it. And when you look at the data that exists, the data says you have maybe a minor improvement in stroke rate, very little. It's not even statistically significant. But when you look at the other metrics, it actually favors on pump. When you look at everyone involved, not your personal case.
I thought we
but
were going to
everybody.
have this debate.
Okay, so let's talk about green dye. What do you think about green dye? I think it was Novadac. Novadac had that thing where you would put green dye in,
What's it
and
called, right?
and
IC
it was
green.
the ICD-9, ICD green,
Yeah.
and you look to see, I guess, the flow through the anatomy, could measure time to measure flow. How does that compare to this technology?
Well, I
More
think,
cumbersome, but
Well, no, I think, you put something in a vessel and it distributes into the distal tree, or the coronary artery in the muscle area. But even if you had a stenosis at the distal anastomosis from a stitch or something, and not a complete occlusion, you would still see perfusion. You'd see flow down.
you'd still see the flow.
You'd see the green.
You'd see right. It would illuminate.
So it's a good general thing, but I don't have much experience with it. I think what we have here gives us real hard numbers and a very good algorithm as to how to intervene and what to do when we do see abnormal findings.
One of your slides, you had that the patient wanted to leave the hospital after CABG surgery and be able to go on and live a normal life free of symptoms. And that was one of the big reasons why you put this up, because if your graft goes down, and that was the culprit graft, so to speak, they're going to have persistent angina after they've left the hospital, and that's going to be very bad. So, and that's a good reason to make this a gold standard. But when you look at the CABG, surgical CABG versus PTCA studies, they all show that having CABG is far superior to PTCA, to stenting, when it comes to freedom from continued symptomology, freedom from symptoms and angina. How does that get reconciled in all of these discussions? Where do we go with that?
I mean, it's an ongoing, battle between cardiologists and surgeons. I mean, the data doesn't lie from that standpoint. And so, the dilemma we are in, and we always have been, is that we're not in control of these patients until they're referred to us for surgery. So, we have to have good working relationships with the cardiologist. It shouldn't really be a battle per se. And it should also has to be a confidence that the cardiologists have in the surgeons that they're sending patients to.
Yeah. How much of that influences it, do you think?
A lot.
That's what I think too. One last question. Sequential grafts. Do you see more problems with sequential grafts if you do them, or if you do jump grafts, one vessel, 2 or 3 anastomoses, distals? Do you see any increased problems associated with those versus a single bypass?
Well, if they're done right, they're better because you have you have better outflow. You would see even a lower pulsatility index, and we do. We didn't talk about it, but we would see that. And we can measure individually. So you can just put...
That's what I was going to ask.
You can, say you had a sequential bypass to a ramus and an OM. You put a bulldog between the ramus and the OM. Now you're just measuring the ramus. You take it off and you measure both. But as long as you improve your outflow, the chances of that vessel or that bypass graft staying open is much greater. The problems is again, typically technical. And if you have people that, surgeons that either don't have as much experience or, just don't know how to lay the vein on the coronary and put that on where there's no turning of the distal anastomosis, that's where you can get into trouble. Again, it's all a technical thing. So if you do a technically good sequential bypass, that graft should stay open even perhaps longer than a single distal artery that you bypass.
I'm surprised by that.
With that being said, I mean, you have your IMA tacked onto the LAD. Would you ever find yourself maybe tacking a graft, a saphenous vein graft onto that lima and putting it onto wherever?
Great question, and has been done several times before.
I've seen it.
And the reason is you do your distal bypasses, you put the mammary on the LAD, and then you go to sew your proximal grafts onto the ascending aorta, and it's a calcified pipe.
Right.
You cannot put a clamp on it, so you have to immediately figure out where you are going to attach your proximal inflow. And the left mammary is a very good place to put it. You can also take down the right mammary and connect it directly to a bypass. I mean, there are different ways to do it, but you have to be careful with the mammary artery. We know that's a patient's lifeline typically, and so we want to make sure that's dedicated to the left anterior descending coronary artery typically. But if you have to do it, you have to do it.
Okay.
I have one more question.
Please.
After you've been using this technology and then identifying grafts that weren't optimal and you had to redo them, have you changed your surgical technique at all? Have you learned little nuances of something that you're like, okay, I see what I did wrong, or not wrong, but different on this particular anatomy?
A great question too. I mean, again, you have to be willing and able to say, hey, we're not perfect. I'm not perfect. We're going to have a stitch that's not placed in the right area at certain times. And the most important thing that this technology allows is for you to identify that and then have the chance to redo it. There's been some times in response to your question where I have done, say, for example, a bypass to the distal right and knowingly put a graft on a vessel that I knew had plaque in it, but there was really no soft spot to put in. And I didn't like the flow rate, so I took it down and I did a coronary endarterectomy and then reattached it, and the flow was beautiful. So, those are the types of things where you say, well, should I have done an endarterectomy to begin with before I did the anastomosis? Maybe, but again, that's why we have the technology and why we have the ability to assess. Because like I said, there's some downsides to doing endarterectomy.
Right. So it's not necessarily next time you would do the endarterectomy, but you're thinking, I might have to do it.
Correct. You just, and again, there is that algorithm that we spoke of. There's a lot of things that are going through your mind when you find the abnormal tracings. When they're normal, it's very easy because you know, okay, well, I've done everything, it looks great, and chances are this bypass will stay open. But it's the abnormal ones where you have to kind of start really thinking and kind of fairly quickly.
Do you do interrupted stitch on your distals, or do you do a
I
continuous?
do parachute running. I've always done it that way. I know people that do the distal
Okay, just
interrupted at the toe, and I think it's a good technique as well.
On the mammary.
On any
It was
distal.
On all
on
distals.
all
On any
distals.
distal, yeah.
Wow. So I worked with a guy that did that. He did 8-0 interrupted on the mammary only, though, on every stitch.
Yeah.
And that was, man, I'll tell you what, those were some long memories.
Our perfusionist is like,
Those were some long memories.
Yes.
Mhm,
Yes.
mhm.
Yes.
Okay,
Have
so.
you considered off pump? That's a new. That's a new thing.
That was funny. Here I was just getting ready to say, I needed these guys to please save that piece of the film that he said he wasn't perfect, please, and that the stitch wasn't exactly perfect, so I can insert because you weren't on pump, because you weren't on pump. Okay,
No.
so
And then, by the way, it happens on pump as well, as
Yes.
we all know.
far more infrequently.